Introduce yourself and then start.
Yes, sir. Good evening, sir. Good evening, colleagues. I'm Dr. Gauri Karbare. I'll be going into third year now currently from Medanta Medicity, Gurgaon. So today I'm doing a case presentation. So
Okay.
shall I start, sir?
Yeah.
Okay. So I'm presenting a case. So we have a 42-year-old gentleman, resident of Hisar, educated till 10th standard, caterer by occupation, post-renal transplant status. So he came to us with chief complaints of fever with chills lasting for a single day, associated with dizziness and a serial rise in creatinine from 1.5 to 2 within a span of 2 days, which he remembers. I would like to date back my history apparently when he was apparently asymptomatic around 5 years back in 2019 precisely, until he started having frequent headaches every few days, for which he went to the local doctor and he was detected to have raised blood pressure. Then he was started on two medications which he knows and remembers to be tablet Telma and tablet Amlo. After that, he did not have any follow up with a physician. Then in early 2022, he noticed shortness of breath, which was earlier on exertion, but later progressed so much so that he could not carry out his daily activities. And he consulted a physician at the end of the entire 2022, finally in 2023. And upon the consultation, blood tests were done, which showed to have a creatinine of 9. That time he remembers only that value. There was no history of any chest pain or any palpitations associated during this 1 year span. No history of any decline in urine output or any hematuria or any pedal edema that he remembers. No history of any fever or cough with expectoration. Upon further evaluation, the doctors told him that his kidneys are small and shrunken. He immediately took a second opinion and went for water therapy at HIMS for 3 months. Then his condition gradually worsened with increasing malaise, loss of appetite, and weight loss around 10 kgs over a period of 3 months. And finally, he consulted the nephrologist in August 2023. So he was initiated on dialysis via a right jugular catheter, he remembers, and he was continued for twice weekly dialysis for 3 months. During this period of time of 3 months, there was no any intercurrent infection, no any hypotension. He also received 2 unit blood transfusion during the initiation of hemodialysis. Following which he found it difficult to manage with the daily hemodialysis because he was a caterer. He discussed with his nephrologist that he would like to opt for a renal transplant. Then among his transplant prospect after inquisition, the donor was Bhabi because the blood group matched with the patient B and B. He said he remembers. So, and she was 49. She is 49 years old, and she was as a potential donor. The transplant workup was started. After dialysis vintage of around 3 months, he underwent live donor renal transplant with sister-in-law as donor on 2nd of Jan this year, 2024. He remembers to have received a costly injection around the transplant period on the day of transplant and post-op day 2, around 90,000 he said. Immediate post-op period, immediate post-operative period was uneventful. His nadir creat went up to 1, but on POD 5, it started to increase from 1.3 to 1.4, gradually to 1.7 on POD 7. Then he was explained by his doctors. I would like to add that there was no any decline in urine output during this period of time. He was explained by his doctors that he would need graft biopsy to evaluate the cause for the rise in creat, and he underwent the same on POD 7. Then, as the doctors also explained him the provisional biopsy report, in which they told him that आपको कोई rejection नहीं है. This is what he remembers. So he told me that. Then he was discharged on POD 9th with creat of 1.4. Drain and Foley's were removed subsequently on POD 7 and 8 respectively. And he remembers that he was continued on transplant medications. Of all the medications, he remembers 3 names importantly only: tacrograph, tablet Imutil, and tablet Bisolone. Since then, he has been on regular follow-up thereafter, and his creatinine level used to remain in between 1.4 to 1.5, has never risen recently. But then, now 4 weeks post-transplant, he presented with the complaints I just mentioned, which were fever with chills since 1 day associated with dizziness, and rise in serum creat from 1.5 to 2 within a span of 2 days, and he was admitted to the hospital on 25th of Jan 2024. Shall I proceed with the?
Yeah. Could you describe the fever a little more?
Yes, sir. So, sir, the fever was high grade, and it was there was no particular evening rise of temperature. Whenever he was having high grade fever, it was associated with chills, particularly. He also vaguely complained of burning micturition associated with the fever, and only one day of meaning episode of dizziness he had, that when he wasn't able to get out of the bed. He said he felt immediate dizziness, and he was brought to the emergency room, he said. Also, on further evaluation, further probing, when I asked him how much was his BP, whether he remembers, because he was in the ER, so he said कि low बताया गया था मेरा BP. Exactly, he does not remember.
Okay, carry on with the
Yes.
presentation.
So, past history. So, he's a hypertensive since 2019, and no history of any diabetes. Family history, his mother and father were non-diabetic or non-hypertensive. No history of any renal dysfunction in the family. Personal history: he consumes a mixed diet, appetite is reduced at present, bowel habits are normal, and he's a non-alcoholic, non-smoker. As for the drug history, he remembers 3 drugs: tacrograph, that is tablet tacrograph, tablet ibutyl, tablet visolol, and 1 medication he takes for his blood pressure, tablet amlo. The rest of the medications he doesn't remember, but when he sees the strips, he recognizes, he said. So, shall I summarize?
Yeah, do that.
Yes. So, to summarize, a 42-year-old male presenting with post renal transplant on 2nd of Jan 2024, basic disease unknown, with background of hypertension, has come to us with fever with chills of 1 day duration. So, acute febrile illness, I would label
Wait.
it as that.
Okay, we'll stop at that.
Yes, sir.
Would you like to start?
So, like you started with chief complaints, you had 3 chief complaints:
Yes, sir.
fever with chills, dizziness, and increased creatinine.
Yes.
So, each chief complaint should be described separately, first of all.
Yes, sir.
And you are saying fever with chills for 1 day along with dizziness.
Yes, sir.
So, dizziness since how long? Since 1 day.
1 day only,
For
sir.
1 day.
Yes, sir.
So, is there any difference of for 1 day or since 1 day? When to use since, when to use for?
Okay.
And why fever and chills are there 2 separate chief complaints?
So, fever was associated with chills, is what I found from the history. Yeah.
And fever is high grade,
High
when you were
grade.
describing, so it
Yes,
was
sir.
documented.
Yes, it was documented.
So
And
can you say in the history that it was high grade? Can
Yes,
the patient tell you that it's high grade, low grade?
yes, sir.
It's our judgment, not patient's judgment. So you can say that it was
Okay.
documented and this much temperature,
Right.
101, 102. Can we say that it's high grade? Can a patient tell you that it was high grade?
Yes, because he, after transplant, earlier he was a very non-compliant patient, but now since taking history, I realized that he takes care of himself. He knows a lot. He has a BP machine at home. He has a temperature, meaning he has
But like in history, we should tell that how much temperature was there. It's
Okay,
documented or not.
Understood,
And there
sir.
are many points in how to describe a chief complaint.
Right.
We cannot just you have tell good history, but like in while presenting the chief complaints, we have to be more elaborated for
Understood.
the chief complaints.
Okay.
Chief complaints were like for only 1 or
Detail.
2 minutes. Like what you say, sir? Like
Yeah, so I've got a few questions for you.
Yes.
Since Dr. Saurav has started with fever, does the pattern of fever, the presence of chills, give you an indication, and associated symptoms give you an indication as to the source of infection?
Yes, sir, they do.
Like, let someone else answer, yeah. What would you like to know in the pattern of fever from her in a post-transplant patient?
Duration between 2 fever spikes.
So when she said it is fever with chills, when a patient with fever develops chills, what could be the causes?
Particularly in this post-transplant 4 weeks after post-transplant, most highly probability of urinary tract infection. But considering
You are thinking of bacteremia.
yes,
Whenever there is bacteremia, the patient develops chills. and some parasitic infections which can cause chills.
Yes, malaria and dengue.
So never forget malaria, dengue, and in post-transplant, when you think of bacterial infections, whenever there is bacteremia, you will get chills. So that's the importance of knowing. Now, is it important to know, like she said, high grade? That's what he was asking. What are the peaks of fever? Was it low grade remittent? Was it high grade continuous fever? Was it intermittent fever? That's important to tell us what is the pattern of fever that the patient has. Okay, now we come back to this case. So, what do you think was the primary disease in this person, 42-year-old person? Let somebody else answer here.
So it is in the short history which was given, like primarily that in 2019 he was when he had headache and all complaints, so he came to know that he was hypertensive at that time, and so only complaint, the first complaint for which he showed to the physician was hypertensive only at that time, and then in 2022 shortness of breath, and the first time he came to government.
So, what do you think is the primary kidney disease? You think it is secondary or is it primary, the kidney disease?
Likely to be primary if he was not evaluated that.
So, the patient came in end stage kidney and he also had hypertension. At this stage, it's almost impossible to tell what was the etiology of the. But what would be the common causes in our country of this age group people going into end stage kidney? I'm not necessarily asking you order wise, but 2, 3 common causes. She didn't give a history of diabetes, and he presented with hypertension.
Chronic glomerulonephritis. Chronic glomerulonephritis.
Yeah, chronic glomerular nephritis due to
IgA
so
nephropathy.
IgA nephropathy.
Yes.
And then which would be the other cause you'd think of?
FSGS can also be a cause.
So if you think of primary FSGS, do they come only with hypertension or they also come with edema?
They come with edema and
So this
proteinuria.
person had no edema. That's what you specifically mentioned.
Yes,
No?
sir. Yes.
And anything else? So you're thinking of bilateral renal artery stenosis. Who said that? Yeah, bilateral renal artery stenosis. By the time they go into end stage kidney, they would have had other manifestations, which has not been described. So it's very difficult to say, but yes, IgA nephropathy is the most common cause. FSGS, yes, but FSGS should present with edema, unless it is secondary. So how do you distinguish primary FSGS from secondary FSGS?
So, secondary FSGS would be the person would have a likely cause. For example, if the patient is obese, then obesity would.
So for secondary FSGS, there has to be an etiology.
Etiology, yes, sir.
Can anyone mention the etiologies? Can you do that? 3, 4 common causes. Secondary FSGS. Anyone? 3, 4. Don't go. I'm not asking for those 10, 12 causes which are given. Mention 4.
Reflux,
But this man is not obese, so don't even think about it. So he thinks of viral
no
infections.
history of fever.
What are the viral infections you think of? And COVID. So this is the viral infections. Then what drugs you think of? Okay. More common, जिसके ऊपर पूरी किताब लिखी गई है 2 वॉल्यूम. Brenner's hypothesis किस पे है? So when there is hyperfiltration, in which condition?
Meaning,
Solitary kidneys.
nephron
No?
endowment.
So you, secondary FSGS, you must have a cause for secondary FSGS, and they usually do not have edema. That's very important to remember. So now, when you go on to the transplantation, you said sister-in-law, ABO compatible, whatever be the blood group. How did you prove the relationship between the bhabi and the patient? Let someone else answer. Yeah, come. How will you prove that this is actually the sister-in-law?
for the sister-in-law and husband, one sister-in-law's husband and their son. It will establish the relation between the husband and the wife. That means the patient's brother and
That means first you say they are husband and wife. And how do you establish husband and wife?
wife, if they have some
A sibling, they have a child, then you do the triangle. Okay, then
and we have that HLA typing of the recipient also, then we will match the HLA typing of the recipient with the HLA typing of the brother.
good. So what are the chances that the match will take place and what degrees of matches can take place?
So it will be 3 by 6 match.
No, you didn't get my point.
Haplo matches.
It can be a nil match, it can be a 25% match, it can be a 50% match, it can be a 100 match.
So the chances of, since they are not the identical twins, so the chances of getting 100% match are 25.
Anyone?
The 25% match.
Can it be a zero match between
Yes.
the two? How will it be a zero match? How will it be a zero match? I don't have a board, otherwise I would have asked you to draw and show me. Can it be a zero match?
Can be.
Can be zero match. Can it be a 100% match? In what percentage? And the remaining?
50%.
Yeah. So when you do the HLA matching in siblings, you must always keep it in mind. And suppose you get a 0% match in HLA, then how will you prove the relationship? You do DNA typing, DNA finger. When you fingerprinting, when you do an HLA match, I'm sorry, I'm going away from your topic. So how do you write HLA match? What is that A, B? What is the first letter? What is the second letter? What's the meaning of star? Have you ever thought about it?
A is the locus and
A is the gene, right? Then after that you've seen some star coming there. What does that star mean? Very good. You've used a DNA based method. It's not a serological method that we used to do 50 years ago. Right? That's the meaning of star. Then what is the first letter which comes? It's the allele. Then after that, again hyphen, and there's some more letters. What is that? There are different names for it, but it is the epitope. So you have a gene. In the gene, you have an allele. In the allele, which is the antigenic determinant, is the epitope. So that is the epitope. And then you go on to then there are two more letters after that. What are those two letters? Yeah, in the coding and non-coding region. So we usually go up to the allele and we stop. What is the importance of going up to the epitope?
Nowadays, in the cases of chronic rejection, we are getting the applets, which are that is the small subset of amino acids, which are now causing the rejections. Now we are studying, so that's why.
So just go into that and see what does that star mean, what does that hyphen mean. In the HLA, next time you get an HLA report, ask them what does this star mean, what does this hyphen mean, and why are we going up to the second space? The importance. All right, thank you. Okay. Then when in the immediate post-transplant period, she mentioned that he had a rising creatinine. In the first 1 week post-transplant,
Yes,
there was
sir.
a rising creatinine.
Yes.
Right. Now, who would like to take to the common causes that we see for a rising creatinine in the post-transplant period? First 1 week. Okay, you think of CNI toxicity. Okay, then. You tell me. I'm asking you. Never mind if you don't know, just tell us. When you get a rising creatinine in the first week after surgery, what are things which cross your mind? How would you sort of ask for investigations? Yeah, why do you, so you think it could be a arterial? Yeah, I'm saying 1 week. So she says she wants a Doppler of what? Which artery? That at the anastomotic site. So you're thinking that there could be thrombosis or stenosis at the anastomotic site, which is leading to dysfunction, right? One, okay. So vascular complications. Second, now first we blame the surgeon for everything, no? So vascular complication. Then what else can he create a problem in?
Sir, if there was any blood loss during the surgery, ATM or
So if the patient is hypotensive when he comes back from the OT, that could have led to an ATM, mild ATM. Okay. Then और सर्जन क्या करता है यूरेटर जोड़ता है so can he create a problem there? There could be an obstruction. So there could be a obstruction, there could be a vascular complication, there could be a, like you said, a hypotensive episode leading on to ATM. Maybe that's why the creatinine is rising. Here from the surgery part of it. Medical part, she said it could be TAC toxicity. Now, what is the protocol that, let's ask any one hospital that you all follow for starting TAC in your patients? The one behind you.
We started on the day -1 0.1 mg per kg of tacrolimus, and then we post surgery we do the tac level 1 post-op-date 2 and post-op-date 5.
Okay, that is your protocol. How many days does it take to follow up? How many days does it take for a TAC to stabilize, TAC level to stabilize? 72 hours, roughly 72 hours. Does anyone follow a different protocol?
We do it on, if we started the EOD -1, we do it on day 3 and then day 7.
Okay. And all your patients are covered by ATG?
Yes, we started two different doses, 0.1 and 0.12, depending on the consult actually who prescribes it. And then ETG is obviously we cover everything.
Okay. So 3 days later you do the TAC level. Now so let's ask the lady in front. So how do you measure TAC?
So we usually do it with a chemiluminescent immunobased assay in the whole blood sample.
Now all the TAC levels mentioned in standard textbooks, by which method do they mention? No.
What should be the gold standard, sir, is asking.
What is the gold standard method? Yeah.
LCMS, sorry.
LCMS,
LCMS.
liquid chromatography,
Mass spectrometry.
mass spectroscopy. That is
Mass
the gold
spectroscopy,
standard.
sorry, yeah.
So what is the difference between LCMS and immunoassays? What is the difference? As a nephrologist, you're going to be practicing third year now. Next year, you're going to be practicing. And different laboratories will give you different reports. No? So LCMX, please know, the advantage is it measures the parent compound. It doesn't measure the metabolites, right? So that is the true value of your TAC. What we do, chemiluminescence immunoassays, the older generations measured not only the parent compound but also the inactive metabolites. So if you got a level of 10 in that method that we are using and a method of 10 by LCMX, there's a difference. The TAC level may actually be low. But now what we do is we use the 4th generation RIA, which is supposed to be as good as LCMX, right? So whenever you get a TAC report, next time make it a point to read by which method they have done it. For example, if you do it in a laboratory which is doing LCMX, and if you do it in, say, our laboratory which is doing by the other method, by chemiluminescence, you may sort of blame the laboratories for giving you different reports. But it's the method which is important. Okay. Now, she said there was rising creatinine and no oliguria. Who will tell me the difference between rising creatinine with oliguria and rising creatinine without oliguria? Let her do.
So what I essentially meant for us.
No, you tell me.
Okay.
Rising creatinine with drop in urine volume?
I would think of rejection
Okay.
immediate in the post-operative period if my patient has rising creat and oliguria, because and also drop in output, hypotension, volume contraction, and can also cause drop in output with rising creat, but it would be fluid responsive likely. Uh, Apart from that, if a patient does not have drop in output, then ATN still can be a cause.
No, what I'm trying to get at is that you may not have a drop in urine volume in cases of rejections.
Okay.
So what she said was, I think of TAC toxicity or CNI toxicity, fine. Then you must also think of rejections that you mentioned. Now, some other medical causes. Okay, we'll come to that. We'll come to that. Anything else? Infections. No?
Yes.
You may have a rising creatinine in the early post-transplant period. He mentioned recurrence of primary disease. Were you thinking of any particular disease recurrence in the second or third day or fourth day post-transplant? You were thinking of recurrence of primary FSGS. Should we deviate a little from your presentation because you come prepared for something else?
No. Yes.
Huh? So, do you think this patient had primary FSGS? अभी तो बात किया, there's no swelling. He didn't come with edema. He only came with severe hypertension. Okay. So, could it be a genetic FSGS? You have primary causes, you have secondary causes, and you have a genetic cause. Could this be a genetic cause for his FSGS? Very good. Well, let one person say. Now, suppose it's a genetic FSGS. So, will it recur in a post-transplant period? No. In fact, it's very safe to do it in them. No, it is the primary FSGS, and that too a particular variety of primary FSGS which can recur so early in the post-transplant period. Okay. Then the fever settled down, the creatinine settled down apparently, and he was discharged at 1.4. Now you mentioned no family history of kidney disease. Why did you mention that?
For his basic disease, I was trying to find out.
So what are the family disorders you look for?
Although in this case, he was already told that it was bilaterally shrunk. His kidneys were bilaterally shrunken. Had, in another scenario, had they been enlarged with cysts, I would think of ADPKD.
One is ADPKD. Then
as a family history.
Any other hereditary disorders?
Nephronopathy.
FSGS, familial FSGS. Then
Nephronocytosis has small kidney.
common things, common. You think of hereditary nephritis, no? You never. And in your history, I don't remember you mentioning about visual disturbances, auditory disturbances, which are very important to mention in all kidney cases. All right? Especially when you say family history, I would expect you to think about hereditary nephritis in this patient. How is it hereditary nephritis? How is it inherited? What are the types you know of? Actually, you are right in the vision, so I keep on asking you. Let's ask. Yeah, you tell me now. Okay, when you get Alport syndrome, is it more severe in males or females? Why so? So, and what are the features of Alports?
Sir, the patient will have sensory lesion deafness. There will be hematuria. Hematuria, microscopic hematuria.
Extrarenal manifestation.
Extrarenal manifestation means patient will have sensory lesion deafness will be there. Patient will have lentifoldness. Lentifoldness will be there. And
He has ocular abnormalities and he has auditory abnormalities. And why is it? Why do they have ocular and auditory abnormalities?
because of the
1%.
it is a type 4 collagen.
Yeah.
Chain of type 4 collagen which is getting mutated. It's also present in cochlear membrane.
Very good. And the descemet membrane of the eye. So the mutation is in what? What does COL stand for? Collagen alpha 4. Okay, alpha. Simple. So right, now let's go on to your case. Up, carry on now.
Shall I start with the examination?
Yeah.
So as of now, my provisional diagnosis is acute febrile illness, urinary tract infection I'm suspecting. So patient was examined on day 3 of admission in supine position. Pulse was 70 beats per minute, regular rhythm, volume was adequate, condition of vessel wall normal. Blood pressure was 140 by 18 millimeters of mercury, right arm supine position. There was no pallor, no edema, or no lymphadenopathy. And on local examination, right supraclavicular small scar mark around 2 to 3 mm was seen. Then on systemic examination, cardiovascular system, there was no thrill or no heave. Apex pit was in fifth intercostal space medial to the mid-clavicular line. S1 and S2 were audible. On respiratory system inspection, bilateral movements were symmetrical. On percussion, bilateral areas were resonant except the left intraxillary area, and on auscultation, there were no bilateral added sounds. On inspection, abdomen was flat, umbilicus was central. There was a linear oblique scar noted on the right iliac fossa, measuring about 7 to 8 centimeters in length, which was well healed. And on palpation, the transplant kidney could be palpated, and there was no tenderness at that point of time of palpation, and no organomegaly was noticed, and hernial orifices were normal. And he was for the central nervous system examination. He was conscious, oriented to time, place, person. There was no focal neurological deficit at that point of time.
Will you also auscultate in per-abdominal examination?
Yes.
What will you hear in that?
Pertaining to this case,
In all transplant, post-transplant cases, will you?
For immediate post-transplant, I would like to see for ileus, if at all, parasitic ileus, if it can come in post-operative period. We usually see.
You will have graft bruit, like you will not miss that in examination part.
Okay.
That is, if examiner asks positive findings, these are the positive findings you will have. Patient didn't have any fistula.
No, he was in just
Only
3
jugular.
months of vintage period of dialysis, so he wanted transplant.
And like in history, you were telling that it's life related.
Yes.
Will it be related like she is sister-in-law?
This will be, but she's still in a relationship somehow.
So what are as per the law, what is life related? That's what he wants to know. As per the act.
So it has to be a blood relationship.
No, there are definitely 6, 7 relationships which are known as related. Yes, madam? Oh, you've answered, the lady in front of you. As per the law, when you say it's a related donor, which are the categories who come under related donor?
Which is the law sir is asking about?
Have you heard about the law, the Transplant Act? Have you heard about it? So you cannot be in third year without having read the Human Organ Transplant Act. Please, your third year? You must go back tonight and read. So anybody can tell? One person. Who said HLA match? No. What about The person right behind, those who came in late. Yeah, yeah. You're from which hospital? एशियन चलो हाँ बोलो भाई बड़ी दूर से आए हो so we want legally related नहीं नहीं just tell me the categories ex spouse then parents sibling good children oh grandparents right so these by law are related the rest all are unrelated by law you must know this huh? Okay.
And you are in your diagnosis, your differentials for according to the history of present illness and past history, you are telling acute febrile illness is your primary diagnosis.
That would be my first differential. Like
so in a transplant case, what will be the first differential if there is rising creatinine? Your chief complaint will not be a graft dysfunction.
Yes, graft dysfunction would be a primary cause, but then
the syndromic diagnosis, will it be acute febrile illness first or graft dysfunction first?
But in my case, he definitively had high-grade fever. I thought it would be unlikely.
Primarily, it is a transplant case.
Yes.
So first, you should say it's graft dysfunction, then your etiological diagnosis,
Right.
in which you can mention about the infective etiology. So what infections you are thinking about in this case?
So other systemic examination, I couldn't find any localizing factor, or there was no graft tenderness. But still, I would like to go with urinary tract infection in this case because patients post-transplant are prone in view of instrumentation. They have stents in situ.
So in your case, was he or he administered IV antibiotics?
Yes, he
You
was
know.
given IV.
So how did you know that he got antibiotics? In history, he told you?
No, sir. In history, he didn't tell me.
In most cases, if in elective surgeries we give, in transplant also we give IV antibiotics. So why we give IV antibiotics in peri-transplant period?
To prevent because we do a lot of instrumentation in the surgery itself.
So which infections we are preventing by using IV antibiotics in first week post-transplant period? Surgical site infection, UTI.
What he's trying to get at is, could you tell me the timetable of infections in the post-transplant period?
So we usually divide it into early transplant, and that is from first.
What's this? What's it called? This chart? Is there any name for this chart? Rubin's chart. Rubin's Fishman chart. Rubin.
Yeah, tell us.
So there is this early transplant period, and then there is after, like between that is day 0 to 1 month, then 1 month to 6 months, and then after 6 months and thereafter.
Okay.
Yeah. So if we talk about from 0 to first month, mainly as we discussed the surgical site infections and all causes for if there is any
all post-operative infections, urinary tract infections, pneumonias, surgical site. Yeah. 1 to 3 months.
Then there will be activation of the latent.
One thing is the donor-derived infections.
Yeah.
In the immediate
So
post.
yes.
Donor-derived infections are immediate.
That will be in 0 to 1. Yes. So there will be all the viral Hep B, Hep C. Then later on in the meaning from 1 to 6, it will be the opportunistic infections, which the latent infections, which like cytomegalovirus. Then there is.
You can categorize as viral, bacterial, parasitic,
yes.
opportunistic infections. And in post, after 6 months?
And still some of it will carry forward like parasitic infections and viral infections, as well as there is the increased chance of malignancies also later on.
Are they infections? Are they infectious causes? We are talking
There
about
are
infections.
infectious causes also for the
So after that, there are community-acquired infections which take over.
Okay, now tell us the labs in this patient.
So he came to us with hemoglobin of 11. I would like to see the complete hemogram since he is admitted. And his total leukocyte count was 17,800. His his neutrophil count was 98. Lymphocyte count was 60.
Can you just give it again? I missed that. What are the counts?
Yes, sir. So the counts were 17,800.
Hmm.
The neutrophils were 98%. And the lymphocytes were 35. And the platelet count was 4,68,000. And I'll go with the urine routine, what he presented with. So urine routine had trace protein, no glucose was detected, and he had around 72 cells in his urine that time. And this is what I saw from the file that I recollected
Okay.
discussing. And apart from this, they had sent the urine cultures. So should I?
Yeah.
Urine culture showed growth of Klebsiella, which was almost pan resistant, but it was intermediate sensitive to colistin at that point of time. So patient was put on colistin.
What was the okay?
And
Great.
blood culture was also sent, but it did not reveal any. It was sterile.
Okay, and blood biochemistry.
Yes. So renal function tests were done. So renal function tests were also done. Urea was 54. Creatinine, when I saw that day, it was 1.7. Sodium was 138. Potassium was 4.9. Calcium was 8.9. His liver function test, SGOT, SGPT was normal. Albumin was 3.4. And even alkaline phosphatase, GGT, and bilirubin were normal. So essentially, LFTs were normal.
X-ray chest.
X-ray test did not reveal any haziness or any localized fat.
And blood culture, you said there was no growth.
No growth. They also did a HbA1c for me. The treating doctor said, although there was no history, since I saw it, it was 5.2.
So that probably doesn't have relevance, no? HbA1c in this patient. Okay. So your patient had a urinary tract infection. Now, how will you treat this urinary tract infection?
So he is 2 weeks post-transplant. He's already on trimethoprim, sulfamethoxazole prophylaxis, but still he's had this UTI.
Yeah. So why do we give trimethoprim sulfamethoxazole prophylaxis post-transplant? Let somebody else from here. Yeah, come. One is PCP prophylaxis. Very good. Huh? No. When we use, which year are you? First year, no? No, it's unfair to ask you. Let's ask the senior batch. Huh? Septran, trimethoprim. Is pneumocystis a fungi, bacteria, virus? What is pneumocystis? Parasite. Anyone? What is the full name for pneumocystis? Carinae. You are in my century. When I passed, we used to call it Carinae. So what did Dr. Kher say? You got to unlearn to learn. No? Yeah. So is it a bacteria or a fungi?
So parasite masquerading as a fungi. So something like that.
Yeah. So it is a transgender. It's a fungi. No? Okay. So what do you use for that? Septran prophylaxis. Anything else? What do you use Septran for? What prophylaxis? UTI prophylaxis. Then toxoplasma use Ceptron? Nocardia for prophylaxis against nocardia. Okay. So he was on trimethoprim prophylaxis. Okay. How will you treat? I asked you.
Yes, so we start on till the culture came, before the culture comes, since he's having high grade fever, I would start him on IV intravenous antibiotics based on if he has previous hospitalization and see the previous cultures available. If I don't have that, he's post transplant and with such high grade fever, so I would like to start him on um, IV meropenem or
You want to start a penem.
pepiprazole, tazobactam or
Okay.
carbapenem.
You want to cover a gram negative organism.
Yes.
Okay.
Cover a gram-negative organism.
Now you've got Klebsiella
Yes.
and you started him on colistin. What is the dose of colistin when you treat any complicated urinary tract infection? First of all, let's be clear. Is it a simple urinary tract infection or is it a complicated urinary tract infection? When do you call a UTI as a complicated urinary tract infection? Let him do that. I want to, so we might as well learn everything on this now.
There is allograft tenderness associated along with fever.
No, sir is asking when will you call it complicated UTI? What is definition of complicated UTI? Anyone? Yeah, please.
Near UTI, so any neutropenia, so any interventional surgery we have done, any
One
analgesic effect,
one is intervention, like Foley's catheter is there,
analgesic effects,
stunt is there, like in this case, stunt is there.
near UTI. Any male UTI is complicated.
All male UTI is complicated UTI.
So we have
You are
to
saying
label as complicated UTI.
which guideline you are quoting?
We book have this.
Every male UTI is complicated UTI. It's not written like that.
No. Complicated UTI has got certain definition. Don't mind. I've got a set of authenticated slides on this. This was a talk taken by Professor Vinay Sakuja on urinary tract infection. That's what I was trying to show him. So you will benefit from what he has done because I took his slides. So when do you say it is complicated urinary tract infection? When there is a structural obstruction, that is one. Like suppose there is a calculi, suppose there is a neoplasm, suppose there is a stricture, or when there is a infection in the prostate, then you say it is complicated. Or if there is a neurogenic bladder. So whenever the system is obstructed, then you call it a complicated urinary tract infection. Or when there is a foreign body lying inside, like a urinary catheter is lying inside, or your stents are lying inside, it is a complicated urinary tract infection. Or if there is an underlying ADPKD or there is diabetes, then all infections are known as complicated. So this is the definition of complicated. When there is an obstruction due to whatever reason, structural or functional, or if there is a foreign body lying in the urinary tract. So that is what he had asked for. What do you think now, your patient? Complicated hai kya hai?
Complicated because the stent was still there in situ when he had this episode of urinary tract.
Okay, so now when you get a urinary tract infection post-transplant, how long will you treat this patient?
So total span of 10 to 14 days.
Yeah, so you will go ahead and give it for at least 10 to 14 days you will treat. Now what is the dose of colistin?
So there's a loading dose and there's a maintenance dose.
Yeah.
Maintenance dose.
Yes.
So 9 million units stat we give loading dose and then 4.5 million units twice 12th hourly.
So
It's a conversion.
So there are various methods of calculating the dose of colistin. There is no one single method, but you must remember all methods are based on the base of colistin, right? To make life easier for you, there is an app, colistin app. Are you all aware of it? You're aware of it? What is that app? No. So what I want to tell you is you might as well go back to your practice with this. There is a Colistin app, if I've still got it with me. Yeah, so Colistin dose, there is an app available. You can download it, it's free. So let's talk about this. What it tells you about the loading dose and daily dose. Huh? Now, suppose you tap on the loading dose. Now, this patient is a male?
Yes.
Okay. What is the rough height?
168 must be.
About 168?
Yes.
168. And what is the level that we want? Now, you must know what blood level that you want. You must give 300 milligrams of colistin base activity. Right? That is what is important. Okay, now let's go on to the maintenance. Having given this, you go on to the maintenance. Now come back to the same. Is he on renal replacement? No. You want a level of greater than 2. Serum creatinine, how much is it?
1.7.
Male, age in years, 45.
42, sir.
42. And what is the weight?
65 kg.
65 kg. kg. Calculate. So it comes to 119 CBA. That is 3.6 million units that you have to give 12 hourly. That's what roughly you were giving. You're giving 4.5, a little higher. So there is no unanimity on calculating the dose of colestins. So whatever you're doing is fine, but there is an app available which you can use it for your convenience. Okay, so you give it for 10 to 14 days. Then what do you do? Do you give prophylaxis after this?
So we continue with our prophylaxis for 6 months post-transplant.
What do you do with the stent?
We remove it 2 weeks post from the day of discharge.
No, patient has got a complicated UTI. The stent is still inside. What will you do?
So it is a nidus for infection.
So
We remove.
you
After the sepsis settles, BP improves, then we can plan for removal.
so you should plan for removal of the source of infection. That is as far as the stent goes.
After removal of the stent, what will you do?
We will continue the antibiotics.
Will you perform an X-ray KUB after that, after the removal?
To check whether it's.
Why there should be a practice of doing an X-ray KUB after removing DJ stent post-transplant period? In this scenario, like in post-transplant UTI,
Good idea.
there are many cases in which there are broken stents which lie inside, and then they are the nidus for repeated infections, recurrent infections.
Any other reason why you must do an X-ray? And look at the, yeah, after you remove the stent, any other reason? One is broken stents. Suppose there's an obstruction at the anastomotic site, then it develops a hydronephrosis, pyonephrosis. So you must always do an X-ray once you pull out the stent, right? And now what happened to your patient after this, after you treated him?
So his stent was removed 2 days later when he received 48 hours of IV intravenous antibiotics, and his fever settled, so they removed the stent, and post stent removal he was discharged after 2 days, so total 4 days of hospitalization, and on the day of discharge his creatinine came down to 1.4. The total leukocyte count also settled from 17,000 to 10,000, and he was afebrile, and it was actually a MDR Klebsiella in the final urine culture growth.
What is the definition of MDR?
meaning,
When will you
it was
call a
panned,
multi-drug resistant?
so it is resistant to two or more class of drugs.
And have you heard about this pan-resistant variety of Klebsiella? Why is it important in our context?
Because if we like in this case, when we encounter MDR Klebsiella, we
Is it
have
common? Is it common in this area, like this part of India?
in tropical countries.
Have you heard about New Delhi bug?
Sorry, sir.
That pan-resistant Klebsiella, which was a strain which was isolated, like grown in around 7-8 years back. It was called New Delhi bug. It was pan-resistant even to colistin.
Okay, so you treat cholesterol, treat the infection, and he goes. So we've also had these cases. Unfortunately, they keep on coming back with recurrent infections. Recurrent infections becomes very difficult to treat this group of patients. Okay, anything else? Now, what happened after this to your patient?
So he came.
Before that, cholesterol toxicity. Third year? Anybody? What you should always remember is besides AKI, we concentrate. Neurotoxicity is a very major problem with cholesterol. They can come with dizziness, with vertigo, seizures. They can come with cerebellar symptoms. So whenever you're giving cholesterol to a person with renal impairment, you must always watch for these signs. Tinnitus, they come up. So that is a toxicity that you must always look for. Did your patient have any toxicity?
Sir, unfortunately, no PD follow-up. I was not there to see.
Okay, so you
At the
didn't know
time
what.
of hospitalization, he received 4 doses. When I saw him, that time he wasn't complaining of any symptoms.
Okay, so you should be careful about cholesterol. Right. Now, suppose there were no pus cells in the urine and he was running high fever, what would you think of?
So I would still start with intravenous antibiotics. Side by side, I would think of rejection because the urine routine did
Okay.
not show anything.
Actually, in the modern age, when we use so much of ATG, we don't see fever with rejection in our patients. We don't see oliguria. All that we see is a rising creatinine in these people. No? Okay. Suppose it was a rejection. Suppose it was a rejection, how would you treat this rejection?
So first we'll do graft biopsy to prove that it is a rejection. In the immediate post-operative period, usually have acute antibody-mediated rejection as a common cause. Then we look at the sensitization history. If there are any markers to prove, sort of to say that this could likely be acute antibody-mediated.
What do you look for ABMR in a graft? Or to how do you diagnose ABMR?
So that's the BAMF classification which we follow. So we'll see there should be evidence of glomerulitis or peritubular capillaritis and presence of any C4D staining in the graft should be there and presence of donor-specific antibodies, that is in the serological component.
The easy way to remember is there should be evidence of microvascular inflammation. It could be glomerulitis, it could be tubular capillaritis. There should be evidence of tissue damage in the form of acute tubular necrosis, in the form of intracapillary intraglomerular thrombi. So there should be evidence of some tissue damage. And third is there should be serological evidence. So when to diagnose ABMR?
If we have either two of these things, then we can diagnose.
So even with a negative DSA, you can have ABMR. You can have C4D negative, you can still have ABMR. But microvascular inflammation should be shown in your tissues to show that. Okay, suppose it is not ABMR. Can it be an acute cellular rejection? What do you see in acute cellular rejection?
Yes, there is the tubular involvement, tubulitis
So you see evidence of tubulitis. You see evidence of, what do you see in the interstitium? Inflammation. Not ifta, you see inflammation. All right? Right. Suppose, yeah.
So the timeline she was talking about the patient was around 4 to 5 days the first time the graft rejection occurred. Wouldn't it go more with acute rejection? And for acute rejection, the number one cause is the cellular rejection
Rather than ABMR. Agreed. Acute cellular rejection is more common, but you can have acute ABMRs also. Right? So that's why we do a biopsy. That if it is an ABMR, we should go on to the next line of therapy in these patients. Okay. We'll put rejection aside since we are dealing with post-transplant infections. 1 to 6 months. What are the common infections you all have seen in your practice?
So, urinary tract infections, we've seen pneumonias also. As patients admit with LRT, I've seen diagnosed tuberculosis with the pleural fluid. Patient just complained of pleuritic chest pain on that basis. Then we've had
You can divide as bacterial, viral, parasitic, fungal.
yes.
So what are the viral infections you've seen?
Cytomegalovirus.
You've seen CMV.
CMV.
Protozoal, what have you seen?
Protozoal. We've seen patients coming in with diarrhea and then they were having giardia or cryptococcus.
Cryptococcus, okay, then?
And
okay, yeah. Yeah, strongylitis. Yeah. Okay. Fair enough. Yeah, that she mentioned CMV. BK she didn't mention, but it's all right. You want to ask more? Now, what is it that you want to clarify from him?
so this patient will be on prophylaxis for 6 months with Septran. How do we prevent the recurrence of such UTIs in such patients?
Even on Septran, you are asking.
We'll keep him on Septran as per our protocol. And he'll have those 14 days of cholesterol. So sir was saying he'll likely come back again with another episode of UTI. Is there anything, sir, which can we do to prevent that? Of course, after ruling out that he does not have any obstructive symptoms.
Like in this case, it was complicated UTI. Digestant, the needles we have already removed. Then there are lesser chances that he will have recurrence if we remove the digestant after that. And that's why we are giving antibiotics for longer period. We're continuing on Septran. You are asking about after 6 months?
No. Just that we removed. So in this case, it's settled. Otherwise, we'll find out things in another patient's, whatever is the likely cause.
It's actually very difficult. We don't have an answer to this. I said, like in our practice, what I do is, fortunately, our Klebsiella is coming sensitive to doxycycline. So we are putting them on a combination of doxycycline and any other antibiotic prophylaxis for 2 months, 3 months, and breaking the cycle. Very difficult question on this. Now, is there any other doubt you people have before I give you something new on this? We are talking about post-transplant urinary tract infections. Fair enough. So what did she told? She told us about post-transplant urinary tract infection. We didn't go into post-transplant pyelonephritis. We didn't go into that. We didn't make an attempt to distinguish between post-transplant cystitis versus pyelonephritis. But it's good to be aware that whenever you get a post-transplant UTI, it's a complicated UTI. You must always suspect graft pyelonephritis as a cause for dysfunction of the graft. Simple UTIs will not cause dysfunction. So when there is dysfunction, you think of pyelonephritis. So the treatment should go on for a longer period of time for post-transplant UTIs. Anything else you all would like to know?
One question I will ask, like in graft pyelonephritis, compared to native kidney pyelonephritis, how does the symptom differ? symptom-wise, what is the most common symptom in graft pyelonephritis and native kidney pyelonephritis?
So in graft pyelonephritis, there will be renal allograft tenderness on palpation.
I'm talking about symptom, not sign.
Symptom. Sterile pyelonephritis.
So that was the question. Will there be will there be pain in graft pyelonephritis?
There won't be pain, but
So most commonly they present with fever only. No, there is no pain in graft pyelonephritis. In native kidney pyelonephritis, the most common symptom is flank pain. It's not there in graft. Why?
denervation because of the surgical aspect of it.
Yeah, so that's a very important thing we didn't cover in our discussion. Lower urinary tract from graft pyelonephritis. Very important to distinguish between the two. Okay, so I think that finishes UTI post-transplant. She gave a very simple case, but we had a good discussion. A lot of simple points you all have picked up. Now something which is new in UTI, not in UTI of post-transplant, that is MV140. Have you all heard of it? So people who have recurrent urinary tract infections, lower urinary tract infections, what we try to do is build up the immunity at the mucosal level. So MV140 is a whole cell heated, inactivated bacterial vaccine which is given sublingually for 3 to 6 months, which breaks this cycle of recurrent UTIs. Now this is in the very early stage, MV140. It's not yet in clinical practice, but you all should know as a part of your knowledge in urinary tract infection. Yeah,
all of you should read European Urological Association's guidelines on UTI. What are the definitions of recurrent UTI? What is UTI? Asymptomatic bacteriuria. All definitions you should learn.
You tell me this, like he's mentioned. What is asymptomatic bacteriuria?
So there will be clinical signs and symptoms, but on examination,
Asymptomatic bacteriuria.
there will be no fever.
Patient is asymptomatic, but you get bacteria in the urine.
Yes.
So now if it's not a transplant patient, asymptomatic bacteriuria, can it have pyuria?
It can have.
Yeah. So will you treat?
Depends upon the patient profile.
So only if the patient is symptomatic, you treat this group of patients. Otherwise, you don't treat. If you have pyuria without bacteriuria, what do you think of? No, you think of atypical organisms. No? And if you have bacteriuria without pyuria, contamination. Right? That's the important thing that you must think of. Then he told you something about recurrent UTI versus relapsing UTI. So what is recurrent UTI? In a year with a clean break in between, a break of 2 weeks in between. And relapsing is as soon as you stop, within a week the infection recurs. That is relapsing. So these are terminologies. I think we'll stop at this. Thank you very much. Now if you all have anything,